for the Minnesota Hospital Association's Endorsed Business Partner Program, which very high level, we hear from our hospital members of a specific need that's out there in the field, and then we go and find companies that we research and vet and who we think can solve some of those problems. And ever since that pandemic, it's certainly been no secret that workforce is a big part of the issues facing Minnesota hospitals. And so today we're welcoming in one of our newer endorsed business partners to share their solution with that workforce piece. So welcome to Synergy Health Partners. And today they're going to be taking a look at the workforce component of surgeons. And I'm happy to welcome today Corey Johnson, who is the Chief Partnership Officer, and Dr. Richard Makovic, who is the Chief Medical Officer over at Synergy. And I am going to disappear and let them take it away. If you have any questions, please feel free to use the Q&A or the chat feature, and we'll be sure to get those answered. So, Corey, all yours.
Thanks, Drew. It's nice to meet everybody. As Drew stated, my name is Corey Johnson. We're super grateful for the partnership that we have as an endorsed business partner with the Minnesota Hospital Association. We're excited to be here today and to share more about our company and our model. Just a couple of housekeeping items before we get too far along. Drew mentioned that we can use the chat feature to track questions. He's been kind enough to track that for us. If we could hold the questions and take care of those at the end of the presentation, I think that would be helpful for Rich and I. But we certainly want to carve out some time at the end to be able to answer any questions and elaborate on any thoughts that you all may have as we kind of go through the slide deck. Additionally, I did want to mention that Rich and I, along with Dan, our CEO, we are planning to be in Minnesota at the beginning of August. That first week of August, we're going to be doing a Minnesota roadshow. We have some appointments on the calendar to stop by and see various facilities already, but that's one of the things that we really enjoy about the work that we do is getting out into the communities, meeting people, seeing hospitals, and really trying to gain a better understanding of the challenges that you all are facing. Rich and I are excited to share our company model today. We're absolutely passionate about helping hospitals, and we're proud that over half of our programs support rural communities. As we go through the presentation, we do want to invite everybody to listen and to learn how facilities of all types use the Surgicalist model to increase surgeries, to boost their revenue, and to serve patients locally where they live. Our company was founded by two orthopedic surgeons about 15 years ago. At the time, the two doctors were working in private practice, and they were trying to come up with a solution that would help them to resolve the care conflict that they felt between, building their own elective practices, but also having obligations with the hospital to cover emergency call, to help out with inpatient consults, and to see those patients that may come through the emergency department. So they had seen what had happened with the internal medicine hospitalist concept, and they asked themselves the question, could we do something similar with orthopedic surgery? So a couple of years later, they started our first program. It was actually out on the West Coast. That program was in Corvallis, Oregon. It was with a level 2 trauma center, and the solution that they designed was purely to take care of the inpatient components. So these doctors were they were taking care of emergency and trauma consults. They were doing inpatients, seeing all those patients on follow-up. And what it did for the community and for the surgeons there is it really freed them up to be able to focus and build their elective practices. That's still an active program that we have today in our system. It's still the same group of doctors that are going up to Oregon every month to take care of that program, but we've been able to expand within the system, and we're now covering about half the hospitals within that little regional system there in Oregon. So obviously over the past 15 years, we've grown, we've expanded. We're really proud of some of the accomplishments that we've been able to do. We're proud, in the number of patients we've been able to serve, the surgeons we've been able to put to work, and kind of the third career path that we've been able to carve out for surgeons. And then we're happy and excited that we've been able to help hospitals to generate revenue and come up with local solutions for their for their patients and the people that live there in their communities. So um, we've expanded. We operate in over 20 states now. So we have a national footprint, a national network of surgeons that help out nationwide. We've gone beyond just that acute care type concept. So we help hospitals not just with an inpatient type solution, but we also help them to build strong and robust elective practices. And there are new specialties that we focus on. We've gone beyond orthopedic surgery. We have a really strong, robust general surgery practice. We help critical access hospitals with anesthesia. And then we're exploring and expanding into specialties like gastroenterology and urology. So I don't need to linger too much on this particular slide, but I did want to talk a little bit about the climate today. It's a tough environment out there, and the challenges are really clear. You all are in this day in and day out, but the demand for healthcare services is accelerating. Patient care needs are becoming more complex. There's a growing shortage of physicians. There's not always alignment between what hospitals are looking for and what physicians are looking for. And then it's certainly a difficult financial environment to operate in right now. I think it's worthwhile to linger a little bit on physicians. The statistics that are on this slide, nothing new to anybody who might be watching this, but every single data point here points to one thing. It points to fewer physicians, fewer doctors in patient care. And it's challenging. I've been working in healthcare workforce solutions specific to physicians for about 20 years now. When I look at the physician shortage, sometimes I like to frame it up in a 30-year window. If we go back to the late 1990s, it was really the Balanced Budget Act of 1997, where in the process of balancing the budget, the federal government, they limited the amount of funding that went to postgraduate medical training. And that fixed the number of residents that we trained each year. So we've been training roughly 30,000 residents a year for the last 30 years. But when we look at the demand side and we look at consider the fact that we've added 60 million people to our general population, that's about roughly the population of the country of England. So we've added people to our population, but we're not just a growing population, we're also an aging population. So as we age, our bodies, require more attention from healthcare providers, and our surgeons and physicians are aging right along with the general population. So it's caused a lot of friction. And we've also expanded access through the ACA and Medicaid expansion. So we've kind of arrived at what we'll talk about sometimes as a little bit of a perfect storm when you start looking at the supply and demand dynamics with physicians. It's not just that we have a shortage of doctors, and this slide just shows the forecasted shortage coming from the AAMC of what might be the projected shortfall of surgeons, kind of where that would range out. But it's not just a shortage of surgeons and physicians, but it's that we don't have the doctors in the right places. There's a disproportionate allocation of doctors and surgeons towards more densely populated metropolitan areas. And we just don't have the surgeons and the doctors that we need in rural markets. And that's where rural communities and people that might live outside of bigger cities, they tend to suffer because they don't have that access. And that's really the focal point of all of this. When we talk about physician services and we talk about the shortage in rural communities, the reason that this is important is because it's fundamentally changed the way that healthcare is delivered. And that's why we need to come up with new and innovative models to be able to, help folks to receive care where they live. And that's kind of, where our model comes into play. And this slide just really provides a bit of a graphic sense of what the model looks like and how it operates. Our surgicalist model is a fractional solution. It's fully aligned with the goals of the hospital, and it's designed to grow volume, to increase revenue, and it brings surgeons from larger population centers to areas of need. So you can kind of see at the top of the slide how it works. Typically, what we'll see is, we form a dedicated care team of surgeons, and then they work on rotation. So one surgeon will work 10 days, then they have 20 days off. They're relieved by the other surgeon. There's coordinated handoffs. We provide the clinical and the service line leadership. We can cover programs, full time, or we can just augment what may be there already. And then we track all the KPIs, the quality metrics, and we put goals around the program. So we're moving towards um, achieving what the hospital would like to achieve with that program. Programs can look different depending upon the need of the facility. Usually, when we're working with a rural community, absolutely, we're going to cover any gaps that may exist in call, but the interest is generally around building up and maintaining an elective practice. So imagine a community-based type orthopedic practice where people can, have joints taken care of. There might be sports medicine. On the general surgery side, a lot of our surgeons in rural communities, they do colon cancer screenings and a lot of scope work to make sure that that need is being met. When we work with facilities that may have a robust group of surgeons, but they just don't want to take call anymore, or they're trying to increase their competitiveness when it comes to recruiting into the facility and alleviating the call burden is of interest. We can kind of carve out that original acute care type solution where our program will handle all the emergency inpatient consults. We see those patients on follow-up, and then it really kind of frees up the community doctors to do more in their elective practices. And then trauma coverage, whether it's a level 3, a level 2, a level 1, we can do a full outsource or we can do an augmentation on any type of trauma program. So at this point, you may be asking yourself, and a question that we get probably on every call that we do is, what's the difference between, what Synergy is out there doing and a locum tenens solution? So the short answer is that there's a time and a place for each, but what really differentiates Synergy is the nature and the role of the care team. I started out my career in 2005. And I spent the first 6, 7 years working specifically in surgical locums solutions. So I was working with hospitals, level 3 trauma centers, critical access hospitals, larger facilities, but we were helping them to fill gaps in their call schedule. So we would get doctors, we would send them to that community. That doctor would have a pager. They'd sit in their hotel when the pager would go off. They'd go in, they'd take care of the patient, then they'd go back to the hotel and they'd wait for the pager to go off again. So the challenge with that model was that there wasn't a lot of consistency. There wasn't a lot of continuity in the surgeons that were going on those assignments. It tended to change over time. And because of that, patient care would suffer, coordination and collaboration with the facilities would suffer. And hospitals even lost revenue because they weren't able to credential the surgeons with their payers and they weren't able to collect and bill those professional fees. So that's why when I learned about Synergy, I was immediately intrigued, by the work and by the mission. But I do want to invite Rich to hop over and share a little bit more. He's on the leading edge of forming and working with these care teams, and he can certainly share more about the benefits of having that dedicated care team.
Yeah, thanks a lot, Corey. As Corey said, I'm Rich Macklitz, Synergy's Chief Medical Officer. I'm also a practicing orthopedic surgeon. And Corey's touched on some of it, but I really want to stress or emphasize the dedicated care team. It is a committed, consistent team of surgeons that come 24/7, 365 days a year. And it's always the same surgeons. That's what's a little bit unique with this versus locums. So that has great appeal to our surgeons in that they also love consistency, but certainly on the hospital or facility side, that consistency builds quality, it builds relationships. So there's significant benefits to this consistent, dedicated care team. The surgeons get to know the OR team. They get to know the ER physicians. They get to know the referring providers. they really become part of the medical staff and the community. They serve on committees within the medical staff. They collaborate on process improvements. That consistency has really made this sort of the next step in their professional career. And so they're very committed to the local facility. Maybe go to the next slide, Corey. Yeah, lots of benefits to that type of consistency. And there's really four that I'd like to speak to specifically. Reduces out migration. If patients are brought to the emergency room and they have something that requires surgical care, knowing that the surgeons are there, they're available, they're dedicated to fixing things in the community, keeps patients in your local hospital. Obviously, a part of that then drives surgical volume. Certainly, it does it on the acute care side. But again, we can craft a customized team for surgeons at facilities that can also deliver elective care to increase surgical volume. Increased surgical volume, direct correlation with increased facility revenue. Keeping patients, their families all in the local facility is one way to keep revenue and the positive impact that has for the facility in the community. And then lastly, it has significant community impact. Improving community health improves patient satisfaction and keeps the hospital at its central role in communities. Maybe hit the next slide, Corey. Yeah, this is really, I think, a critical component of what we do. And you may ask, how does Synergy find the right surgeon and the right fit? We have a very extensive recruiting process. We do a deep discovery on the facility and hospital side to get to know our partners. Who are they? What do they want? What type of surgeon will fit best in their community? So we combine the surgical skills that are needed. And again, this is a collaborative effort with the facility to determine, do they need joint arthroplasty services? As Corey mentioned, do they need general surgeons that can provide colonoscopy services? So we get the skill side right, and then we get the cultural fit right. And again, what that does is it forms a lasting relationship between our surgeons and the local facility. So with Synergy, you've got a partner that's actively engaged. We want this to be a success, both for the facilities and the surgeons. We have frequent communications, robust data tracking. We make sure that the program is successful. A couple things on, how do you get a surgeon, and what is it like to work with Synergy? Well, similar to Corey, I'd been in practice for 23 years before I found out what the Synergy Surgicalist model is, and my own reflection on that is, this is fantastic for surgeons. I have a peer group. We're all experienced. We've all been in practice 20 to 25 years, and we'd love to continue to do what we do, but maybe not at the pace we've been running for 25 years. So Synergy has great appeal to experienced surgeons who are looking to work a little bit less, get a little bit better work-life balance than they've had their whole career. We easily come across team players who are committed to continuing in their practice and provide a high level of excellence and quality. But at the same time, they gain this work-life balance. And we think this can be a real career extender for surgeons. This reduced pays, better work-life balance may allow more surgeons to stay in the field longer as opposed to retiring early. And that's certainly another way to address a bit of the surgeon shortage that we've seen. But again, because it is the next step in their career and it's consistent, they're always going back to the same place. They tend to get involved in communities. They can sometimes staff high school sporting events. They serve on committees. They want excellence from the facilities. They can provide that by offering their experience. And again, consistent, dependable surgeons. Recruiting is an interesting aspect because when you tell surgeons about this, the model essentially sells itself. We have people who reach out to us. We have surgeons within our network referring other surgeons, but we take this very seriously. Every surgeon is interviewed by another surgeon, and that's always a surgeon within their own specialty. So We have general surgeons interviewed by general surgeons. Orthopedic surgeons are interviewed by myself or another orthopedic surgeon. We do a pretty thorough vetting process, looking at case logs, background references, et cetera, to make sure, again, we've got the right surgeons with the right skill sets, and then matching them up with a facility where they're going to be able to contribute greatly.
Yeah, and I would just add, Rich, I think that, we certainly do a lot of due diligence on the front end when we're learning about not just the scope of work and kind of that thumbnail sketch of what the role would entail, but we spend time with facilities. We'll go on site. We will meet with facility leadership to try to get a feel for the culture. We want to be able to kind of experience the community so that we can really draw those parallels and draw some of those enduring matches as well.
Absolutely.
So this slide, thank you, Rich, for your comments. This slide is really just kind of a time frame on, what it would look like when we stand up a program. Um, we guide around 6 months. It can certainly happen much faster than that. What we've found over the years is that state licensure, facility privileges, payer credentialing, these are some of the things that can delay starts or extend starts out. But we found that where we have positive collaborations and partnerships with our clients, and everybody's acting on clients or acting on candidates rather with urgency, moving things along, trying to find ways to expedite privileges. We can start programs much faster. We've started programs in 90 days and 120 days. Every situation tends to be a little bit different. The reason that the slide says, 4 times faster, starts is simply because when you look at how long it takes to hire a doctor, a surgeon on a permanent basis, a facility could be looking for 2 or 3 years to find that right fit and to get that doctor there. And we can stand a program up much faster. So we've had facilities that have utilized our solution to build and stand up a program. And then over time, they slowly sunset it while they recruit on their own and are able to recruit into a robust and built out program. Um, the structure of the work that we do or the nature of our programs, it's very flexible. We can scale up or down depending upon the needs of the client. We can build multi-specialty disciplines within what would normally be a single hire or an FTE. For example, with orthopedic surgery, if we have 3 surgeons that are coming out on rotation, we can determine what those subspecialties are. So we could have somebody that focuses on total joints. You could have a generalist. You could have a sports medicine doctor, and all of that can be predicated on what the need is there in the community and what the patients would need. Um, all of the surgeons are 1099 contractors to us, so it's really easy for us to make personnel changes when that's needed. Again, we do put a lot of time and effort into finding the right people and understanding the fit. But every once in a while, something will happen where we do need to make a change, but we're able to do that quickly. And when we do make a change, unlike traditional employment, if we do have to make a change or a pivot, we still have part of that team that's there over the transition. So the program's really durable versus hiring somebody on a permanent basis, having them leave and go somewhere else, and then having to kind of reinvent that process and constantly be starting and stopping different programs.
That's a real key point, Corey. The service line doesn't collapse because you've always, with this fractional model, have some element of the team in place. So I think that's a critical to maintaining flow of patients and a reputation for being able to provide a service in that community.
Yeah, thank you. Wanted to share a case study or an example of a client that we're working with. I'll go through, a few of these slides, and then Dr. Makowitz will, who's worked, directly with this client for a number of years, will provide his commentary here at the end. This particular client is located in Montana. They're lovingly referred to as the middle of nowhere. Statistically, I think it's the most remote community in the lower 48 states. But they were in that situation that the Rich just described. They had an orthopedic surgeon that was employed full-time by the hospital. The doctor decided that they were going to leave. They were going to relocate to Texas. And the facility, was concerned that if they weren't able to backfill that position, that the program would deteriorate and they would never get it back. So they brought Synergy on board, and we solutioned out a program for them that provided them with 24/7, 365 availability for orthopedic services. That included coverage for the emergency department, surgery, follow-up and post-op care. We did a fracture clinic, and then they actually built and stood up an elective practice with that. So as we got going, we had to establish vendors, supply chain, operations. We stood up the clinic. We promoted the service throughout the community so that referring physicians knew that it was there and the community at large knew that that service was there. We sourced and recruited a team of 3 full-time surgicalists to support the program in the beginning. And then as we progressed, we grew that to beyond just the 3 full-time surgicalists. We have 2 PRN surgeons that are on staff now. The partnership is going on 5 years. We've been able to grow their volume by 40%, and their patient satisfaction scores are over 90%.
Yeah, just to add some more color to that, the success of the orthopedic program was so well received by the administration and the community that they also went through service line expansion, meaning we also added a general surgery program at this facility in a similar model, 3 surgeons rotating on a 10-day basis, consistent surgeons year over year. And this experienced team of surgeons, again, works with the hospital to meet the needs of the community. And in this particular facility, like Corey said, what we've been able to do is if a patient needs a knee replacement or if they need a colonoscopy, they no longer have to drive 150 miles to get that. So it keeps those critical health services in the local community.
Yeah, and I think even Rich, they were able to get the joint arthroplasty certification.
That's 100% right. They achieved the advanced total hip and knee replacement certification from the Joint Commission. And we think we've been able to play a role in this hospital consistently being named one of the top 100 critical access hospitals in the country. And as Corey said, the relationship's been going on for 5 years now across multiple service lines. And again, just to frame this, again, think about colonoscopy and cancer screening. If patients are asked to drive 100 miles or more to do it, they won't. And so we think we're helping the community health in a fairly profound way.
Perfect. Thank you. Just to kind of reiterate, I know we've talked about a handful of these items. Again, our goal is to really help people to perform more surgeries, to increase revenue, keep that care local or keep it within your walls. There's a lot to be gained by having surgeons within a community or within a medical staff, by way of facility revenue, and the downstream revenue that would kind of trickles through to the ancillary services by the hospital. We mentioned previously, and it's accurate that the surgeons that work through our models, we credential them with the facility payers, so they're able to bill and collect professional fees. There's a big impact that a doctor, a surgeon, a practice can make on a community when you start looking at jobs, wages, state and local tax base, and that type of thing. And then what we like to call the halo effect. I think when folks know that the service is there, they're going to utilize that. And when they start coming to your facility for one particular service, they tend to come back for other services, and they tend to bring the family. When we put together a program, we don't want any surprises. Our cost structure is predictable. It's cost certain. There are a handful of different components to cost. The largest component is the compensation for the surgeons. We cover the malpractice insurance, and then there's just the overhead of the practice and the management fee. The way that we bundle all of this together is there would be an annual subsidy. It's a number that's consistent for a 3-year period for the term of that contract. And The client just pays a monthly fee at the beginning of each month for the services that are rendered. So we do want to thank everybody for your time and the opportunity to share. Based off what we've discussed and what we shared here, I feel it's clear that the surgicalist model positively impacts hospitals through increased revenue, enhanced volume, and high quality local patient care.
Yeah, and as Corey said at the beginning, we're really happy to answer any questions you might have. We're also going to be on the road in Minnesota and would love to learn about your hospital, your facility, any challenges you have with surgeon staffing, and maybe explore how this surgicalist model could help your facility.
Yeah, guys, thanks so much. I had a question come in about just kind of the scope of the work. Corey, I know you touched on it a little bit earlier. It's kind of general and orthopedic, but there is expansion lines. Are they here? When do they estimate to be available? Or can you say any more about that type of expansion?
Yeah, so the critical access or the critical access anesthesia service line is something that's it's complete. It's in place now. We acquired an anesthesia practice, a small anesthesia practice, a number of years ago, and we've kind of carved out that niche for us. So we're certainly ready and able to offer that solution to any critical access hospital that may need that support. Gastroenterology and urology are programs that we're actively working on and pursuing. We're in the process of setting up a handful of pilots. They're new specialties for us. So we've kind of taken some time to get to this point. We wanted to ensure that we could do our due diligence and make sure that we felt comfortable in our understanding of that specialty and our capacity and ability to be able to recruit. But yeah, we're off and going on all of those. So if there are folks that have interest in those conversations, we'd love to connect.
Yeah, and just to add a bit more on those on the anesthesia side, the programs can be CRNA based, they can be MD based, they can be hybrids. We are very comfortable with each of those. And then also just want to make sure you understand we have subject matter experts both in anesthesia as well as urology that can contribute to our own ability to deploy a successful program.
Great. And folks, please feel free to use the chat and the Q&A. I've got one other one that's come in. People are welcome to type additional ones while we wait. But do you have a makeup of what like the ideal client would look like? Who are those people that you think, or those hospitals that you think would be best served by this solution?
Well, I'll take I think we can ping pong back and forth on this, Corey.
Sure.
So I'll take the level 2 trauma centers first. Those facilities have an obligation to the community and to maintain their accreditation to have orthopedic and general surgeons on call and available. And as Corey noted earlier in the talk, community surgeons don't have as much interest in taking call as they used to. So those facilities are ideal for outsourcing trauma and acute care services. And again, we do that both on the general surgery side as well as the orthopedic surgery side right now. And those are on the orthopedic side, trauma fellowship trained orthopedic surgeons bring a real high level of care. And on the general surgery side, critical care fellowship trained. So we can really bring the skill set to whatever the facility needs. But maybe, Corey, you can talk about the
Yeah.
elective test side.
Yeah, I think to Rich's point, I would say about 70% of our programs, come to us through a critical access hospital, a level 3 trauma center, or a level 2 trauma center. And I think it's pretty clear to see why critical access, it can be a very challenging recruiting environment. So the model has has a little niche there. And then the trauma centers, they just have those requirements around coverage, and it tends to be a good solution for them too. We are starting to see more programs with short-term acute care facilities that might be more of your traditional community hospital, whether it's independent, whether it's part of a small or regional system, or even some of your national systems. We have contracts with all types of different facilities. The need can look a little bit different. From time to time, we'll talk to a hospital that has a partnership with an orthopedic group. They're covering their call, but they also have an ASC. and they're kind of maybe picking and choosing what cases they want to take back. So we tend to get in situations where hospitals are trying to take advantage of market opportunities, or maybe trying to level the playing field against people that they partner with, but they're also kind of competitors. So we tend to see a handful of different scenarios, but that's certainly an area that I've noted in the last year, is we're starting to see more traction and more growth.
Great. So I just had one come in here. Can you speak a little bit about, is this service typically utilized by a hospital that has no services today and is looking to start from scratch, or is it more used by somebody looking to supplement their additional maybe one surgeon that they have on the team?
Drew, that's a fantastic segue, because the model's totally flexible. And so by that, on the supplemental side, if you have a single surgeon there, it's difficult or challenging to have them cover call every day of the year. So our programs are sometimes brought in to supplement on that acute or call coverage side of things. And one of the benefits others have seen with this is when we take on that acute care or the call coverage, it then becomes easier to recruit an elective surgeon as well, because they know that call burden is not there with that. So the supplemental role, we see that all the time. We have also stood up complete orthopedic service lines de novo in facilities that have never had those before. And it's a typical practice building ramp up. It takes time to get referral patterns reestablished and build the volume. But once you have it, and again, we think it's a durable solution, that service line can be a real contributor to the hospital.
Terrific. I think you guys have emptied the queue of questions, so I appreciate both of you with your insights, and this innovative solution, I think, has a lot of potential for many of our Minnesota hospital members. So thanks so much for your time and your talents here in sharing that with our hospitals. And for all of the attendees and registrants for today's webinar, I will be sending out the slide deck and the recording of today's webinar here later this afternoon. So thank you, everybody, for joining us, and hopefully you'll join us the next time MHA has an endorsed expert webinar series. In the meantime, everybody have a great Wednesday. Thanks, everyone.
Thank you.
Thank you.